Good evening, everyone. So, I'm just waiting for the confirmation of audio and video, and then we'll start. If anyone is there online, can just write in the comment section if the audio is fine. Okay, so it's a go ahead. Okay, so once again, good evening, everyone. Myself, Dr. Rijul Agarwal. I'm the orthodontic faculty at DAMS. Sorry for the delay in the yesterday's section. I was not feeling well, so I was not able to take the session yesterday. Okay, so beginning with the topic is biology of tooth movement, more of a theoretical topic. In the end, when we'll discuss about the drugs and all, we'll touch more about your MCQ point of view, but nevertheless, one needs to understand this part as well. Okay, a lot of speculations coming up about your NEET exam in the previous few days. Pattern कैसा होगा, क्या duration and all that. My only advice for is that, see, इस time पे there is a more of a psychological war kind of a thing going on between everyone. Okay, and because in the end सबने पढ़ाई उतनी कर ही ली है, the exam is getting postponed repeatedly. जनवरी का शेड्यूल दिया, जनवरी went, February is there, still no notification or date until now. So this will keep on going on. कोई ना कोई कहीं से speculations लाके कुछ ना कुछ करके panic create करना and all that. This is absolutely normal which occurs every year. So इस time पे the one person who wins this psychological war will perform well in the exam. Okay, so that's the only message which I can give. I am not here to give you any kind of speculations or what. Okay, कि ये होगा ये नहीं होगा. I'm only here to tell you कि just keep your mind focused and study and relax as well. Since the exam dates are not there, minimum 1 to 1.5 months will be given from the date the prospectus or the advertisement is released for your exam date. It won't be like that today's exam is late and it would be in the next week. They will have to give you ample amount of time for filling up the forms and all that. Okay, so you can study and relax a bit and do not pay heed to any such kind of speculations or advertisement or YouTube videos by so and so person that claiming this will happen, this won't happen, this is happening. Okay, this is all going to add up to your anxiety and going to trouble up you more. Okay, basically उससे कुछ होने नहीं वाला. That's all I can say. Okay, so beginning with the session, the topic is biology of tooth movement. Okay, so what, before beginning with the biology, one needs to understand the histological structure of the bone. So what is the three types of bone which are present? So first is the woven bone, which is compacted to form the lamellar bone, and intermediate to that is the composite bone. Okay, so we can divide into three parts. First is the woven bone, which is the first form bone, and lamellar, which is the last bone, and composite bone is the intermediate formed bone. Okay, just okay, so जो पहला बोन बनेगा, that is the woven bone, will be immature. Okay, loose in structure histologically, and जो lamellar, that is the final or the last bone will be compact, more organized in structure, and more resilient in structure. Okay, so this first form bone is generally formed at what site? At the site of, in first of all, in embryo, next at the sites of fracture, next at the site of orthodontic tooth movement. Why? Because at orthodontic tooth movement there is pressure is applied, the bone is resorbed, and subsequently a new bone is. So the first bone in a site of orthodontic tooth movement is the woven bone, and your final bone, and that is the laminar bone, is the final organized structure. So where it is found? It is found in the approximately 99% of the skeletal system. All the long bones or the bones of the skull are composed of laminar bone only. और जो intermediate form bone है between woven and laminar is the organizing structure which is formed. Okay, so to differentiate them in the form of table, this is the, so the woven is a weak, disorganized or poorly mineralized bone. The laminar is the final bone which is strong, highly organized and well mineralized bone. Composite bone is the intermediate bone, intermediate between that of woven and laminar bone, which are organized or remodeled to form the final, that is the laminar bone. So distribution, it is formed first after orthodontic loading, not found normally, more than 99% of the adult human skeleton, and it is composite is predominantly in the stabilization during early retention or post-operative healing. So it's intermediate between these two. So the formation woven is compacted to form composite, composite is remodeled to lamellar, and finally it's the cancellous compaction. What is the orthodontic significance of this? So woven bone is resorbed if prematurely loaded. Important aspect of orthodontic retention following orthognathic surgery. Laminar is the final bone. Full strength of laminar is not achieved until about 1 year after completion of active treatment. Okay, and there is another fourth kind, that is the bundle bone. So what is a bundle bone? It's the functional adaptation of laminar to allow attachments of the tendons and ligaments found adjacent to the periodontal ligament. Okay, and where is the periodontal ligament? It provides insertion to the Sharpie's fibers. Okay, so these are the four kinds of bone. Very important, the MCQ में जो commonly when they ask you, the first form bone after orthodontic loading is woven bone. Okay, so woven, it varies considerably in structure, weak, disorganized and poorly mineralized. Crucial role in wound healing by rapidly filling osseous defects, provides initial continuity for fractures and osteotomy segments, strengthening a bone weakened by surgery or trauma. So it is the first form bone in response to orthodontic loading and generally found in the adult skeleton, not found in the adult skeleton under normal steady state conditions. Lamellar bone is a strong or highly organized structure which a well mineralized tissue makes up more than 99% of the adult human skeleton, and composite is the intermediate bone, and it's the quickest means of producing relatively strong bone. So अगर composite structure है, सबसे quickly we need, if you want to produce a strong bone, is through quick organization or mineralization of this composite bone. And lastly, bundle bone. Bundle bone is a functional adaptation of the lamellar structure to allow attachments for tendons and ligaments. Okay, so these are the three, or you can say four kinds of bone. So beginning with the theories of tooth movement. So first is the pressure tension theory given by Schwartz in the year 1932. So what does it say? अगर हम इसका if you want to understand the simplified version of this, what it says is, whenever a force is applied on a tooth, it leads to creation of a zone of pressure and tension at different areas. So supposedly this is a tooth, force is applied on this crown region. What it will do? It will lead to creation of pressure and tension zone. So kahan, in which area which zone will be created? The force applied on the crown portion, from the labial aspect, the tooth will tend to rotate or tip like this. So there will be pressure zone at the apex and at this region, and subsequently there will be tension zone on the opposite aspect of it. Okay, so what it says is, wherever there is a pressure zone, there will be bone resorption indicated by minus sign, and wherever there is tension zone, there will be bone deposition indicated by plus or positive sign. Okay, so to understand this in the form of a flow chart, changes in tension zone. So a force is applied, it will lead to stretching of PDL fibers, leading to dilation of blood vessels. Wherever there is dilatation of blood vessel, there will be increase in the oxygen supply, increase in the blood flow, leading to increased oxygen supply. So what will happen? There will be, as a result, there will be increased osteoblastic activity, and osteoblasts are required for bone formation. Likewise, changes in the pressure zone. So a force is applied, what will happen? Force applied, there is the development of pressure zone. So what will happen? There will be compression of PDL fibers and blood vessels will occur. So what will happen? The PDL fluid is expressed, there will be decreased oxygen supply will be there. So what will happen? Decreased oxygen supply, say there will be now be two scenarios which can develop. Either there can be partial compression of blood vessels, or there can be complete compression. So what partial means? Some amount of oxygen supply is maintained at that area. So it will lead to hypoxia like condition, means increased CO2 leading to osteoclastic activity, and complete will lead to hypoxia. Definitely hypoxia will be there, and in addition to that there will be necrosis. And as we know from a pathology, what is necrosis? It's a dead and debris tissue is there. So what will happen? In partial compression there will be frontal resorption. So I'll be denoting resorption with the minus sign, means the bone in front of it will be start to get resorbed. Whereas in complete obstruction, what will happen? There will be rearward or backward resorption. So what do you mean by rearward or backward resorption? So students, what happens is, whenever a force is applied leading to complete obstruction, so what will happen? Due to complete obstruction, there won't be any supply of cells there. Okay, why? Because the blood flow is completely obstructed or stopped at that site. So no osteoclastic or osteoblastic or any nutrient supply can come to that area so as to remove or re-establish that supply back. Okay, so the cells now have to come from some other side or from the back side from where the resorption can occur, so that the blood flow can be re-established. That's why there is a term known as rearward or backward resorption, means the site away from the site from where this complete obstruction has occurred. Okay, that's known as rearward or backward resorption. So following application of mild force, the periodontal ligament is compressed to almost 1/3 of its original thickness. So what are the changes following application of heavy forces? The roots closely approximate the lamina dura, compressing the blood periodontal ligament and leads to occlusion of blood vessels. And the pain is felt normally after 3 to 5 seconds of heavy force application. A very, very important statement for your MCQ point of view. Okay. So what is direct versus undermining or backward resorption? So as I've told you, direct is that the osteoclasts are formed directly along the bone surface adjacent to the periodontal ligament. Whereas what is undermining or rearward eruption is that when heavy forces are there, are used, there is blockage of blood vessels. Okay, so what will happen? This will lead to necrosis of the periodontal ligament and formation of zone of, most important term is zone of hyalinization. So what is a zone of hyalinization? I hope you have understood what is rearward or backward or undermining resorption. Means behind the site where active necrosis are. So hyalinization means it's a first of all a pathological or a histological depiction. As we all know, you don't have to confuse this term with the hyaline connective tissue. Okay, it's not hyaline connective tissue, that's a separate thing. Okay, this is a zone of hyalinization. So what happens is this osteoclasts, as they appear adjacent to the bone marrow spaces where this active necrosis is happening, so they attack from the behind or underside of the bone immediately adjacent to the necrotic periodontal ligament. That's why it's known as undermining or rearward resorption. So hyalinization means is denoting a avascular area of the periodontal ligament, means the cells disappear in that area. So it denotes a avascular or completely hyalinized. So अगर हम इसको, if we want to denote it using a H&E staining, if you remember from your oral pathology or histological classes, there will be appear as completely eosinophilic or completely purple or hyalinized area on the histological side. That's why for your MCQ point of view, it's known as hyalinization and not hyaline connective tissue. Okay, so what is hyalinization? Is a form of tissue degeneration which is characterized by formation of clear eosinophilic homogeneous substance. It's a local cell-free area of overcompressed periodontal tissue. Okay, so another important point, it is normal even with light forces as well. Okay, so if you can get it as a point of assertion reasoning type of question, the hyalinization zone is normally even formed under light forces as well, and it takes approximately 2 to 4 weeks for this zone to get clear. Why? Because the remodeling of the necrotic pedicle takes time. Next, what is secondary remodeling changes? Okay, so secondary remodeling changes are the changes which happen to maintain the width or thickness of the alveolar bone. So students, please understand, whenever there is active deposition and resorption occurring, supposedly if you want to understand, if you remember from postnatal growth, there are certain surfaces which are undergoing resorption, there are certain surfaces which are going deposition. So the nature or the human body or biology is such that they have to maintain the thickness of the bone. So there will be always subsequent deposition of bone on the opposite side of that of resorption. Okay, so in orthodontic aspect, if you want to understand, there is example that if a tooth is being moved in the lingual direction, there is compensatory deposition of new bone on the outer side of lingual alveolar bony plate. Okay, and also a compensatory resorption on the labial side of the labial alveolar bone, which keeps on occurring so as to maintain the width and thickness of the bone. Then it will never happen that subsequently the resorption is occurring and the bone gets thinned. Okay, the alveolar plate or the plate gets thinned out like this. There will always going to be a deposition of bone on the opposite side. So this term or this subsequent deposition and resorption on adjacent surfaces is known as secondary remodeling changes. Okay, I hope I'm clear. So this concludes our first pressure theory, that is the pressure tension theory. So moving ahead is the next theory, that is the fluid dynamic theory or the blood flow theory. So It was given by Bean in the year 1966. So what basic premise it says that the pedial space is consists of a fluid system with a confined passage, and passage of for what, for providing in and out movement of the periodontal ligament fluid, and this space is limited. So this acts as a hydraulic mechanism and a shock absorber. So imagine a long beaker, if you remember from your chemistry, and a ball is thrown inside that beaker, fluid filled beaker. So what will happen? The ball will grow out and the fluid will get try to compress out of that liquid. Okay, so similar is a, so that beaker is the confined bone and that ball is the tooth inside that beaker. So this fluid surrounding it acts as a hydraulic mechanism and a shock absorber. So according to this theory, the movement occurs as a result of alteration in this fluid dynamics in the periodontal ligament. So unlike the beaker, which is a continuous thing without any holes, the periodontal or the bone surrounding it has holes, certain holes which act as a shock absorber. So whenever tooth is pushed, the fluid escapes out through those holes. Okay, so to understand this, we'll understand this in the form of a flow chart. So what happens? The fluid is trapped between the tooth and socket. So what will happen? Whenever the tooth is compressed or moved inside, it moves, the fluid moves towards the neck of tooth and apex. So what will happen? It acts to cushion the load, which is the known as the squeeze film effect. So what is the squeeze film effect? So we'll come to this diagram. So imagine this is the periodontal fibers and the tooth is surrounding here. So what will happen? Whenever the tooth is pushed, and how it will be pushed? Through orthodontic forces. What will happen? The fluid will escape out through this. It will get squeezed out through these small holes. So this is known as squeeze film effect. So what will happen? This film, the periodontal liquid film, becomes depleted at this continuous pressure. So what will happen? The film is getting depleted. Why? Because it's squeezing out from this surrounding structure. अगर ये continuous this squeezing will occur, what will happen? Subsequently the fluid will totally get lost or go out. So that does not happen because it's a biological system, not a physics experiment. So what will happen? There will be occurrence of a damping effect. What is this damping effect? This damping effect is the method to replenish or rejuvenate the expressed out fluid back into this system. So what will happen? There is now exhaustion of this extracellular fluid and subsequently the tooth is intruded. Okay, so this, as I was saying, this damping effect, okay, is generated. So why? So as to replenish this system is generated by the fluid dynamic system. Okay, I hope I am clear. So this is the diagram. Okay, so what is happening? There is compression of periodontal ligament and occlusion of blood vessels. There is formation of cirrhoid aneurysms, a very important term both for understanding this theory and for exam point of view. So what is this cirrhoid aneurysm term? So this aneurysm acts as spring between the tooth and alveolar bone. So what will do? It will help in replenishing the squeeze film. As I was telling, the film which is squeezed out needs to be replenished. It does not happen कि वो चल the fluid is lost, it is gone permanently. It needs to be replenished or come back. So it helps to dissipate the kinetic energy which is applied to the fluid as they are forced out through the vessel wall. So this is the function of this aneurysm leading to the damping effect. So what will happen? When this fluid is pushed out, there will lead to the alteration in the chemical environment. So what is the alteration? There will be a decrease in the oxygen concentration in the compressed area. The gases escape into the local environment and there will be increase in the carbon dioxide and monoxide gases. So these are all favorable for the resorption of bone, leading to the movement of tooth in the intended direction. I hope I am clear now. Okay, so to summarize, the orthodontic force is applied. This is just a summary on the fluid dynamic theory. The free squeeze film effect comes into play. The film is exhausted. There is cavitation which occurs past the constriction of these cavities, which is caught between the tightened periodontal ligament fibers. These minute free gas bubbles form in interstitial tissues from the gas diffusion through the vessel wall. The lodgement of these gas bubbles under and between the spicules of bones creates a favorable local environment for bone resorption. Okay, so this is the fluid dynamic theory. So next is the third, which is the bioelectric theory, also known as bone bending theory, given by Farrar in the year 1876. So why this theory came up? Basically, it tried to explain the beginning of tooth movement, how the tooth movement starts whenever we apply forces. So to understand this theory, first we need to understand the two concepts, that is piezoelectricity and streaming potential. So what is piezoelectricity? So this term piezoelectricity was given by Bassett and Becker. It is observed in crystalline structure. So what are the crystalline structure in human body? These are the bone, the hydroxyapatite crystals which are present in tooth enamel, and one non-crystalline structure which exhibits piezoelectricity is a collagen. Very important for an MCQ. So what is piezoelectricity? Whenever a force is applied to the structure, what will happen? Force apply ki, it will lead to deformation of the structure. Whenever there is deformation by this external force, it will lead to the production of electric current. So this current which is produced by this deformation of the structure has two characteristics. That is, first, it will have a quick decay rate. The charge will set up and subsequently it will drop down to zero within a few milliseconds. And next characteristic will be, there will be a production of an equivalent signal in opposite direction when the force is released. So these are the two characteristics of piezoelectric currents. So next comes streaming potential. So what is streaming potential? So streaming potential is the ions in the fluids which surround the bone. Okay, so when they interact with this complex electric field generated when the bone bends, as a result, currents can be detected in the extracellular fluid. Okay, so surrounding structure, whenever there is, so as I have told you, piezoelectricity is a small electric currents which are generated, and streaming potential is a longer counterpart of these piezoelectric. So whenever in orthodontic treatment, whenever we apply force, the forces are of long duration, so it will lead to bending of the bone. So this piezoelectric currents get converted into a long potential or long currents known as streaming potential. And like piezoelectricity, there will be a generation of equivalent charge in the opposite direction. Okay, so they have a long decay period, and they are also known as stress generated potential or streamlining potential because they are generated as a result of force application. Okay, so these are the two things which we need to understand before we begin with this theory. So coming up with this theory, so whenever a force is applied on a tooth, the alveolar bone in that area bends. There will be occurrence of areas of concavity which are assisted with negative charge and convexity which are assisted with positive charge. Okay, so to understand this, supposedly this is a tooth structure and there is a surrounding bone. So whenever we supposedly apply force, the tooth is attached to the periodontal ligament and this is the surrounding alveolar bone. So tooth, bone and the periodontal ligament. Force is applied, the periodontal ligament will, in one region it will stretch, in another region it will compress, and surrounding bone will also bend according. So there will be generation of convexities and concavities, and the charge which will be generated will be equal and opposite in those regions. As we all know, the tooth is surrounded by the periodontal ligament, which is bathed by a periodontal fluid. So there will be a stress or streaming potential generated in that, and an equivalent and opposite signal will be generated in the bone. Okay, so in the bone, when there is areas of concavity, like here. Okay, so when there is areas of concavity, there will be negative charge, means there is bone deposition, and when there is areas of convexity, there will be positive charge leading to bone resorption. So if we understand this from a diagram, हमने यहाँ force apply की, the bone bends, there will be convexity. So here there is convexity, here there is concavity. So concavity means negative charge, bone deposition. Convexity means positive charge, means bone resorption. And subsequently, the fluid surrounding them will have a opposite charge generated due to the streaming potential. Okay, so this is, so again, to understand this with the help of a flow chart, what happens is force causes deformation of the crystalline structure, which causes dissipation of electrons, which causes generation of electric current known as piezoelectricity, which results in bone remodeling. Simple. The one thing which you need to remember in this is where there is concavity, where there is convexity, and where there is accordingly positive and negative charge. Okay, so this alveolar bone flexing and bending leads to the generation of electric signals which alter the metabolism of bone. So what are these electric signals which I have just studied? These are the piezoelectric currents, these are the bioelectric potentials, and lastly these are the streaming potential. Okay, so this alteration causes remodeling of bone and subsequently tooth movement. Okay, so these are the three theories of tooth movement. So coming to the summary of biology, tooth movement. So this flow chart summarizes these tooth movement. So what is happening whenever there is force application, there is extracellular remodeling is there, leading to cell surface alteration and the reorganization of the surrounding cytoskeletal structure. So what happens in the mineralized tissue, there are osteocytes which when get activated to convert into osteoblasts or osteoclasts, leading to bone formation or resorption depending on the function. The non-mineralized tissue, that is the surrounding periodontal ligament, there is development of compressive and tensile forces in them, and accordingly they undergo reorganization for tooth movement. Next are the blood vessels, which can undergo reorganization or angiogenesis depending upon the type of force which is applied. And lastly are the neural tissues. Now these neural tissue releases certain kind of growth factors which modulate the growth and development of the surrounding. So based on what kind of factors are released, the subsequently resorption and deposition of bone will occur. So these growth factors are the cytokines, the CSFs, and the growth promoting factor, which leads to a inflammatory response and subsequently orthodontic tooth movement. Okay, so these factors are very important for your MCQ point of view, because there are certain drugs which can alter this tooth movement. How do they alter? They alter by modulating these levels of these growth factors, so which we are going to study in the next step. So from here comes the concept of primary and secondary messengers. So what are primary messengers? Primary messengers are the messengers which take the signal from the outside surface to the cell, and secondary message are the messengers which take the signal from the cell surface to the nucleus. If we remember from our basic cellular biology from our 6th, 7th, 8th classes, we know that nucleus is the brain of the cell. So whatever signal has to come, it has to modulate and reach the nucleus, so that subsequent remodeling and modification or subsequent action can be taken. Okay, so this primary messengers activates the extracellular signal which bind to the cell surface receptors. Example are prostaglandin, the hormones, the substance P, and the vasoactive peptides. And secondary messengers are the one which convert this extracellular signal into the intracellular. So examples are the ATP to cyclic AMP, which activates the release of calcium. Okay, so next important thing is that these secondary messengers are only released after 4 hours of sustained pressure. Okay, so this 4 hours numerical value is very important. Why? Because any kind of orthodontic force, if it is not applied for more than, if it is applied for less than 4 hours, won't bring about any kind of effect or tooth movement. That's why during normal mastication, or if we bite certain hard thing, there is no such orthodontic or tooth gets moved. It is only gets moved when there is the force or the pressure is sustained for long duration. Sudden biting on a hard object or clenching of teeth won't lead to any kind of orthodontic tooth movement. It will only lead to grinding or loss of enamel, and no such tooth movement. Only through prolonged action of prolonged forces such movements occur. So again, another important table for your exam: how much time and how much duration after which the subsequent movement occurs. Okay, so you just need to remember after what time, 3 to 5 seconds in divided into heavy and light pressure, minutes, hours, approximately after 4 days or 2 days, how much after how much time duration, which event is occurring. It's a very important table for your exam point of view. Next comes the phases of tooth movement, which was given by Burstone. So there is an initial phase, there is a lag, and there is a post lag phase. So initial occurs due to sudden tooth movement of displacement of tooth in the socket, and it is usually approximately 0.2 to 0.25 mm and occurs in a week's time. Lag phase, there is no tooth movement and occurs with heavy forces due to the formation of zone of hyalinization, and lasts for 2 to 3 weeks, can extend up to 10 weeks. Post lag is the phase where frontal resorption begins and when maximum tooth movement occurs. So if we want to denote them with the help of a flow graph, so if the x-axis पे है tooth amount of tooth movement and y पे है duration, so lag पे initial phase, then lag phase there will be any no tooth movement, and post lag phase sudden tooth movement, like this. Okay, so these are the three phases of tooth movement by burst. Next is the optimum orthodontic force. So what is the optimum orthodontic force? So force at which the tooth moves most rapidly in the desired direction with the least possible damage to the tissue and with minimum patient discomfort, and it's equivalent to 20 to 26 gram per square centimeter of the root surface area, and it was defined by Oppenheim and Schwartz. The lag phase of tooth movement is minimal and there is no marked mobility of the tooth which is being moved in such scenario. Okay, so question, the minimum orthodontic force. So the minimum orthodontic force should be less than the capillary blood pressure. So that's why I posed this question, because in the previous slide I have told you about optimum orthodontic force. Now here the question is about minimum orthodontic force, and it should be less than the capillary blood pressure. Next are the types of forces. So there are three types of forces. There are continuous, interrupted, and intermittent. So continuous forces are the one which are maintained at some appreciable fraction of the original form from one patient appointment to the next, and it's in the hand of the orthodontist. Example, the nitrile coil spring, the elastics which are inserted by the operator. Interrupted are the one in which the force level declines to zero between activations. Example, screws, springs, etc. Intermittent, the level declines to zero intermittently when the orthodontic appliance is removed by the patient. So example is all the patient activated appliances such as the removable plates, headgears, and elastics. So these are the graphical representation. So continuous, the force declines, again reactivated, declines again. Interrupted, there is a certain lag phase in which subsequently we activate. And intermittent, the patient takes out the appliance, so there is some appreciable amount of force, but it declines to zero whenever the patient takes out the appliance. Again inserted, the appliance gets back to the original force. So the optimum forces for various tooth movements are mentioned here. For tipping, translation, uprighting, rotation, extrusion, intrusion. And for bodily movement, it's mentioned. So the most difficult movement in periodontal compromise or in adult with deep bite and loss of periodontal support, the following tooth movement should be avoided. That is the intrusion movement. Intrusion is the movement which requires the least amount of force and it's the most difficult one. Simplest is tipping, and the one which requires maximum amount of force is translation or bodily movement. Okay, and one more thing, the one which is the easiest is the extrusion. Okay, extrusion is so easy that even if you just place a bracket and band the teeth, the extrusion will occur. You don't need to even put a wire for extrusion. You need to find ways to control that extrusion. Simply putting up separators also between the teeth, elastic separator, will lead to extrusion of teeth. Okay, next comes the effects of drugs on the orthodontic tooth movement. So as we all know, I have told you about the concept of primary and secondary messengers. So there are drugs which are there to actively modulate them. So they are very important for your MCQ, as I have told you. So there are NSAIDs which reduce. Why? Because they mediate the prostaglandin pathway, they inhibit it. If you remember from your pharmacology, aspirin reduce. COX-2 inhibitors have no effect. Okay, so the acetaminophen, which is the brand name of, comes under the brand name of Tylenol. Not in India, in United States. In India it comes as Crocin. It's a weak COX-1 and COX-2 inhibitor, so no effect. Okay, so vitamin D receptors present on both osteoblast and osteoclast, which increases orthodontic tooth movement. Fluorides reduces, bisphosphonates reduces tooth movement. Important in treatment advice hormone replacement therapy for such patients undergoing orthodontic treatment. Estrogen reduces orthodontic tooth movement by stimulating osteoblast. Oral contraceptives reduces tooth movement. Hormones, thyroid hormone increases. Relaxin, that is a pregnancy hormone, increases orthodontic tooth movement. Calcitonin reduces orthodontic tooth movement, stimulating osteoblast. Parathormone increases tooth movement. Prostaglandin inhibitors, example are the corticosteroids, increases tooth orthodontic but greater retention is needed, and NSAIDs inhibit conversion of arachidonic to prostaglandin. Prostaglandin E2, low doses increases tooth movement, high doses lead to root resorption. Rank OPG and rank rankle pathway, if you remember. Rankle is a ligand or a receptor activated of nuclear factor kappa B ligand and rank receptor. So the rank receptor is present on osteoblast. Subsequently, when OPG osteopetrogrin, your rankle binds to it, leads to its activation or deactivation. So the OPG secreted by osteoblast competes with rankle to inhibit osteoclast. So we all know the pathway from a pathology. So this ratio of the rankle OPG determines the tooth movement. Subsequently, this interleukins 1, 2, 3, 6 and 8 and TNF, tumor necrosis factor, increases orthodontic tooth movement. Okay. Just a minute. Sorry for the interruption. Okay. Next are the tricyclic antidepressants, the antiarrhythmic drugs, the antimalarial drugs, the methylxanthine. TNF, how to increase tooth movement. Tumor necrosis factor, I think you're asking how it increases tooth movement. TNF stands for tumor necrosis factor. It leads to deposition or dissolution of activation of osteoclast. Okay, subsequently osteoclasts are activated, it will lead to bone resorption and increase orthodontic tooth movement. Okay, I hope I'm clear. Next are these drugs. Okay, so which of the following enzymes decreases orthodontic tooth movement? So option alkaline phosphate, cyclooxygenase, metalloproteinase or protein kinase. So the question is asking about decreases. So alkaline phosphate, how? Because it stimulates the deposition of bone by activating osteoblast. So adds calcium and phosphate ions, increases the calcium content and inhibits the tooth movement. Bisphosphonates, it's a drug for osteoporosis which inhibits osteoclast and decreases orthodontic tooth movement. Corticosteroids increases tooth movement. Acid phosphatase, protein kinase and metalloproteinase increases tooth movement. Which of the following drugs is better analgesic for orthodontic? So as I've already told you, the answer is acetaminophen. Because why? Because it's a weak COX-1 and COX-2 inhibitor. Okay. So the last topic from biology of tooth movement is root resorption. So what is root resorption? So whenever we apply force or the pressure on the tooth, so the tooth, as I've already told you, there is a structure, there is dentine, and in surrounding in the root is cementum. And as we know from our DADH that cementum is softer or less hard than the enamel. So whenever there is pressure on it is applied and it increases its reparative capacity, so what will happen? The cementum does not get rejuvenated or replenished. So what will happen? Cementum hat gaya, the dentine below it comes in direct contact with the surrounding multinucleated odontoclast, which now starts to, now the function of this odontoclast was primarily to resorb the bone. Now what will happen? Cementum is gone, the tooth is exposed. Now these odontoclasts will now start to resorb or the root as well. So whenever the pressure increases beyond the reparative capacity of the cementum, it leads to the exposure of the underneath dentine and subsequently its resorption. So in orthodontics, the term is OIEAR. It stands for orthodontically induced external apical root resorption. So whenever there is, as I've already told you, the hyaline tissue is formed, the removal of hyaline tissue leads to the removal of the cementum, cementoid and the mature collagen, leaving the raw cemental surface below which that is readily attacked by the dentinoclast, and subsequently the root gets resorbed and shortened with time. So it is of three types, that is surface, inflammatory and replacement resorption. So what is surface resorption? So histologically you will see it as micro defects on all surfaces of the roots and they repair themselves. Okay, they tend to stop whenever we remove when pressure is removed. So whenever we remove the pressure, the surface resorption or these defects automatically repair themselves. Next comes the inflammatory resorption. So what happens? Whenever this resorption progresses into the dentinal tubules or below which the dentinal tubules are the pulpal tissue. So what will happen? This will lead to it become infected and necrotic. Okay, and lastly is the third kind, that is the replacement. So here what is happening? It is getting replaced. So what is getting replaced? The periodontal or the surrounding structure is getting replaced by bone. So what will happen? It produces ankylosis of the tooth. Okay, so these are the three kinds of resorption. So what are the predictors of root resorption? First, the greatest predictor is in orthodontics is propensity or genetic. If during an orthodontic treatment you have a patient whose sibling or someone else from their family has undergone treatment and have undergone similar problem, there is 100% chance that the same patient will have the same tendency of root resorption as well. Next, age. So it is seen or said that with increasing age there is an increased propensity for root resorption. Why? Because the bone turnover rate now gets slower down with age. Okay, next is the sex. So it is seen that females have more tendency than males for root resorption. Next, the type of tooth movement which is we are doing. So it is seen that intrusion type of tooth movement. So it is seen that intrusion leads to more root resorption. Next, where the movement is occurring. So if we are moving the root or tooth towards the cortical plate, it will lead to root resorption. Next, the duration of treatment. If the duration of the treatment is prolonged, a long-term orthodontic treatment is going on, it will increase the propensity or tendency towards root resorption. Okay, what is the treatment? The treatment lies in determining the predictors. Okay, so try to have the treatment as early as possible. Do not delay the treatment. Okay, the forces for the movement, tooth movement, should be low. It shouldn't be too heavy forces. The type of tooth movement, the where the tooth is being moved should be determined. Okay, so lighter forces, slower rate, these are all the things which can be done to avoid root resorption. Okay, so any more questions or any doubt? So that completes our biology of tooth movement. Okay, so there are certain risk factors of biomarkers associated with the root resorptions are as well. So I cannot cover them in the allotted time. Okay, otherwise it will lead to confusion. So I've tried to cover the biology of tooth movement in a very short and crisp manner. Okay, if anyone has any doubt, we can write in the comment section or message or direct messages as well. We'll be happy to answer. Okay, from this biology, there are certain, the most important from your INI point of view is they are asked about certain biomarkers as well. Okay, activity ratio, Rankel OPG ratio. Okay, so they are important. Rest all the basic theory important points I have covered. If anyone has any doubt, you can write in the comment section and I'll be able to answer it. Otherwise, I'll close the session. So I just can say keep studying. Okay, the any day, any date, the whenever the dates come, the now you don't have that excuse that a time was less, internship did not get over, this and that. Now everyone has got ample amount of time from the so-called proposed date of the exam of 30th January. Okay, so all I can say is keep away from misinformation, because when the information will come, it will be uniform for everyone. Latest suggestion please, that's all I can suggest for you. Just keep studying and keep away from misinformation, that's all I can say, because these things will keep on circulating from one or the other thing sources. Someone will say this, someone will say that. Okay, expected date, that's what I was telling. Okay, if you want my honest answer, your preparation should be such that the exam is next week. That's how we used to study in you will think that bolna आसान है, but that's how we used to study, that the exam, your mind should be such prepared that the exam is next week only. Okay, so I'm expecting by March, if you want my opinion or my information, I don't have any such kind of inside information, but I'm expecting them to be in March end to April first week, exam day. Okay, I was avoiding to say that because now some might get complacent or like that. Okay, TNF, how to increase tooth movement, that's what I mentioned. TNF is, I think you're asking about tumor necrosis factor. Tumor necrosis factor increases tooth movement by resorbing, activating osteoclast, leading to bone resorption and subsequent increase in tooth movement. I think I mentioned it here in this slide. It leads to activation of osteoclast, which leads to bone resorption and increased tooth movement. Okay, so I'll just close the session now. I hope I am able to